Achieving consistently reliable mandibular anesthesia has always been a problem. In this tape, we will review the classical technique of mandibular anesthesia and introduce more recent techniques. The goal of this is to help the doctor to increase the success rate in obtaining profound mandibular anesthesia. Let's begin by reviewing the preparation of the armamentarium and the patient for all intraoral local anesthetic injections. Examine the anesthetic cartridge carefully for defects or cracks before placing it into the syringe. Engage the harpoon in the stopper by applying gentle finger pressure on the thumb ring. Place a guard on the needle cap to minimize the risk of accidental needle sticks. Then place the needle on the syringe. Check the completed assembly to make sure that anesthetic solution flows through the needle. The syringe is now ready for use. A small quantity of topical anesthetic ointment is placed on a cotton swab to desensitize the soft tissues at the site of needle insertion. It is essential to review a completed medical history questionnaire to determine any history of adverse reaction or allergy to foods and drugs. An in-depth dialogue of the patient's medical condition is recommended to uncover any special concerns regarding infection control or anesthetic administration. Blood pressure, heart rate and rhythm, and respiratory rate should be monitored and recorded before the administration of any injectable pharmaceuticals. Whenever possible, the patient should be placed in a supine position. Head and heart should be parallel to the floor, feet slightly elevated, minimizing the occurrence of cerebral ischemia. Prepare the tissue by drying it gently with a sterile dry gauze. Then place a small amount of topical anesthetic at the injection site. Leave the swab in position for at least 1 minute. The outermost 2 to 3 millimeters of soft tissue will be desensitized. To minimize psychogenic responses, the syringe should be passed to the doctor out of the patient's sight. This may be accomplished by passing it behind the back of the chair or in front of the patient, but held low below the patient's field of vision. For safe and painless injections, placing the extended ring finger onto the barrel of the syringe increases stability by providing a tripod-like effect. The classical inferior alveolar nerve block will provide profound pulpal anesthesia in the mandible in approximately 85 to 90% of our patients. The goal in the inferior alveolar nerve block is to deposit the local anesthetic solution at or above the mandibular foramen. The most common reason cited for a failed inferior alveolar nerve block is placing the anesthetic below the mandibular foramen. Consistently reliable results have recently been achieved with the Akinosi and the Gow-Gates mandibular nerve blocks, which suggest depositing anesthetic at higher sites along the lingual aspect of the mandibular ramus. Let's look at this technique in a clinical situation. When administering the right inferior alveolar nerve block, the right-handed doctor should be seated in the 8 o'clock position. Note the finger rest on the patient's chin, which further helps to stabilize the syringe. The coronoid notch, the greatest concavity on the anterior border of the mandible, is located and the lingual soft tissue is retracted with the index finger. With the barrel of the syringe placed in a corner of the mouth on the opposite side, the pterygomandibular raphe is located. The raphe is the extension of the retromolar pad and will represent to us the posterior border of the mandibular ramus. The tip of our 25-gauge long needle is moved half the distance from the raphe towards the finger in the coronoid notch, and then half the distance back towards the raphe. This locates our injection site, which is found 3/4 of the distance from the carotid notch towards the raphe. Only move the needle tip, not the syringe barrel, which is kept immobile in the corner of the mouth. At this injection site, the needle is advanced slowly through the soft tissue until the lingual aspect of the ramus is contacted. There is no need to deposit anesthetic solution as the needle is advanced through this tissue. Aspiration is performed at least twice, and if negative, 1.5 mL of anesthetic is injected slowly in approximately 1 minute. The needle is withdrawn, and if the buccal soft tissues overlying the molars require anesthesia, the long buccal injection is administered. To anesthetize the long buccal nerve, the remaining 0.3 mL of local anesthetic solution is deposited into the mucobuccal fold, distal and buccal to the last tooth in the quadrant. Following the inferior alveolar nerve block, the patient should be returned slowly to the upright position. This appears to help speed onset of anesthesia in this injection. When administering the left inferior alveolar nerve block, the right-handed doctor should sit in the 11 o'clock position. The carotid notch is located on the left side with the thumb or index finger, whichever is more comfortable. The barrel of the syringe is placed into the corner of the mouth on the opposite side and the pterygomandibular raphe located with the needle tip. Move the needle tip half the distance towards the finger in the carotid notch and then halfway back towards the raphe. At this injection site, gently insert the needle until bone is contacted. If no bone is contacted, do not inject any anesthetic solution. If bone is contacted with less than half of the long needle in soft tissue, do not inject. In both situations, the needle must be partially withdrawn, reangulated, and reinserted to a more appropriate depth of soft tissue. When the appropriate depth is reached, aspiration is performed at least twice, and if negative, 1.5 mL of anesthetic solution administered slowly in 1 minute. The needle is withdrawn, and if necessary, the long buccal nerve block administered distal and buccal to the last molar in the quadrant. Reposition the patient upright following completion of the injection. Before leaving this technique, here are some suggestions for a more effective inferior alveolar nerve block. Firstly, depositing the anesthetic solution higher is better than injecting lower. Always contact bone. If bone is not contacted, don't deposit the anesthetic solution. The average depth of soft tissue in this injection is about 25 millimeters, or 2/3 to 3/4 the length of a long dental needle. And finally, after the injection is completed, reposition the patient upright. This will help to speed the onset of anesthesia. Mandibular teeth anterior to the molars can achieve pulpal anesthesia by administering the incisive nerve block. In this injection, we will be depositing local anesthetic outside the mental foramen. By forcing the anesthetic solution into the foramen with finger pressure, the incisive nerve can be blocked. To do this, use a 25 or 27 gauge short needle. After locating the mental foramen on an X-ray or by palpation, approximately 1/3 of a cartridge of anesthetic solution should be deposited outside the mental foramen. Bone should not be contacted during the injection. After recapping the needle, firm finger pressure is applied for 1 to 2 minutes, either extraorally or intraorally. A major benefit of the incisive nerve block is that pulpal anesthesia is achieved of the mandibular teeth anterior to the molars, but lingual soft tissues are not anesthetized. All primary teeth can also be anesthetized with this technique. Let's see how this is applied clinically. To easily administer the right mental or incisive nerve block, the right-handed doctor should sit in the 11 o'clock position. For the left mental or incisive nerve block, the doctor should be seated in the 1 o'clock position. To administer the right mental and incisive nerve block, a 27 gauge short needle is inserted into the buccal fold adjacent to the mental foramen. Over a period of 20 seconds, 1/3 of a cartridge of anesthetic should be administered following negative aspiration. The mental nerve block, providing anesthesia of the lower lip, skin of the chin, and buccal mucous membranes, is now complete. To provide pulpal anesthesia of the mandibular bicuspids, canine, and incisors, pressure is applied either extraorally or intraorally over the mental foramen for at least 2 minutes. The Gow-Gates mandibular nerve block was first introduced in 1973. This injection presents several advantages. Firstly, it only requires one injection to achieve profound anesthesia of the entire mandibular quadrant. A long buccal injection is not needed. The success rate in a Gow-Gates injection, once the doctor learns the technique, is usually 95% or higher, significantly higher than the inferior alveolar nerve block. It is a safer injection in that the positive aspiration rate in the inferior alveolar nerve block is approximately 10 to 15%, where in a Gow-Gates injection it is only 1 or 2%. And lastly, there are fewer post-injection complications. Trismus, or limited opening of the mandible, is a very rare complication in the Gow-Gates injection. Let us now go to the clinical situation and see the Gow-Gates injection administered. The extraoral landmark for the Gow-Gates mandibular nerve block is the intertragic notch, located just below the tragus of the ear. The barrel of the syringe should be oriented along a line drawn from the corner of the patient's mouth towards the intertragic notch. With the barrel of the syringe placed in the corner of the mouth on the opposite side, the tip of our 25-gauge long needle is placed immediately below the mesiolingual cusp of the maxillary second molar. This establishes the height of injection. The actual injection site, however, is found just distal to the second molar. Leave the barrel of the syringe in the corner of the mouth while moving the tip of the needle straight back distally until it is located just behind the second maxillary molar. With the patient's mouth kept open widely, the needle is inserted and advanced until bone is contacted at the neck of the condyle. Following negative aspiration, 1.8 mL of anesthetic solution is deposited in 1 minute. Following the administration of the anesthetic, ask the patient to keep his mouth open for a full 2 minutes. Returning the chair slowly to the upright position will accelerate the onset of anesthesia. The Akinosi mandibular nerve block is a closed-mouth mandibular nerve block. Advantages of this technique is that the mouth need not be open to give this injection. It is a very effective technique when trismus is present, and in fact, it is a successful injection where the inferior alveolar nerve block and the Gow-Gates injection cannot be given. Disadvantages of the Akinosi nerve block is that it is difficult, because the mouth is closed, to visualize the path of the needle as the needle is inserted into tissue. Secondly, there is no bony contact in this injection, which makes the injection atraumatic, but also makes it a little more difficult to determine the appropriate depth for the injection. To establish a correct height of injection, the barrel of the syringe is placed at the height of the mucogingival junction, which is the junction between the attached and unattached gingiva in the maxillary arch on the same side as the injection is to be administered. The actual site of needle penetration in the Akinosi technique will be the soft tissue on the medial or lingual side of the mandibular ramus, which lies directly adjacent to the maxillary tuberosity, as noted in this picture. When seen from above, you will note that the needle passes through the soft tissues on the lingual of the ramus. In the average-sized adult, the depth of needle insertion from the penetration site is 25 millimeters. This should bring the needle tip into close proximity to the inferior alveolar nerve as it travels from the mandibular foramen towards foramen ovale. It is important for the success of the Akinosi mandibular block that the bevel of the needle be oriented away from the ramus. A 25-gauge long needle is recommended. Let's return to our doctor and patient and see the Akinosi mandibular nerve block administered. For both the right and left Akinosi mandibular nerve blocks, the doctor should be seated in approximately the 8 o'clock position. Using a 25-gauge long needle with the tip of the needle at the height of the mucogingival junction of the maxillary molars, the needle, with the bevel facing away from the ramus, is inserted to a depth of 25 millimeters from the insertion point directly adjacent to the maxillary tuberosity. Following negative aspiration, 1.8 mL of local anesthetic is deposited slowly and the needle withdrawn. On completion of the Akinosi mandibular nerve block, return the patient slowly to the upright position to help speed the onset of anesthesia. In addition to sensory anesthesia, the Akinosi technique will provide motor paralysis, leading to decreased muscle spasm and increased range of motion. The periodontal ligament injection, or the PDL, makes it possible for a dentist to get anesthesia of one tooth in the mandible. In addition, with the PDL, the lip and the tongue are not anesthetized, just the single tooth. To do the PDL injection, you can use either a traditional aspirating type syringe or one of a variety of pressure type devices. To properly administer the periodontal ligament injection, the needle, a 27-gauge short, is placed intraproximally and advanced apically along the root of the tooth until resistance is encountered. A volume of 0.2 mL of anesthetic is then deposited slowly under pressure on each root of the tooth. The anesthetic solution will diffuse through the interproximal bone towards the apex of the tooth, providing profound pulpal anesthesia. To properly administer the periodontal ligament injection, the needle should be held parallel to the long axis of the tooth. To do this, the doctor will most often be seated in the 11 or 12 o'clock position. Using a syringe designed specifically for intraligamental injections or a conventional aspirating syringe with a 27-gauge short needle, bevel facing the root of the tooth, the needle is advanced apically until resistance is met. Under pressure, 0.2 mL of anesthetic is deposited in not less than 20 to 30 seconds. There should be resistance to the injection, and the soft tissues in the surrounding area should become ischemic. If the tooth has more than one root, repeat the procedure on each root. Done properly, the PDL injection should be entirely atraumatic. Consistently reliable pulpal anesthesia is occasionally very difficult to achieve in the mandible. In this tape, we have demonstrated a number of injection techniques that provide clinically effective mandibular anesthesia. Continued clinical practice is essential to maintain proper technique. Remember that the only teeth that require a mandibular nerve block are the molars. All other teeth, the bicuspids, the canines, the incisors, and the primary teeth can be anesthetized with the incisive nerve block.